Moving on to the next topic, you can expect a lot of questions from this topic in your exams. Geriatrics is a very favorite topic of the MRCP, both for the part 1 and the part 2 exams as well. Please go, anyone volunteer to read the first question. So, this is an 85-year-old lady who has diabetes mellitus and she presents with sudden onsets of wild flinging movement of the left arm, which importantly disappeared during sleep. What is the most likely explanation? So, what is this clinical condition called?
Balismus or hemibalismus.
This is not a focal seizure, doctor. It is disappearing during sleep.
Mm.
So this is actually a
Subthalamic.
hemibalismus, that is correct. And the presence of diabetes makes it quite likely that the patient would have a microvascular or a macrovascular complication. So how do you localize the lesion? And in this patient, where is the lesion?
Subthalamic nucleus.
Are you asking or telling, doctor?
Telling. Subthalamic nucleus impact.
Anybody else has any different opinion?
Contralateral subthalamic nucleus.
Okay. So that is correct. And this is hemibalismus. This is not epilepsy. So you have to remember that hemibalismus is always unilateral, and you can have movement in either your arms or legs, but it is not uncommon to find a movement in both the arms and the legs. Okay, and the activity, the movement, involuntary movement, they become worse with activity and they become better with relaxation. Okay, and the site of the lesion is the subthalamic nucleus of the basal ganglia, which is actually responsible for inhibiting the involuntary movements. So that is where the lesion is localized in this case. There are other causes as well. You can have a post trauma. You can have a hyperglycemia. So this is also something which you need to keep in mind. Very important differential. A malignancy, a primary or a metastatic malignancy, any vascular malformations, or any demyelinating plaques, which is again very common in elderly patients. Now, a 73-year-old lady presents to her primary care physician with fatigue and lethargy. Her husband has noted a change in her character and her hair has become thinner. She complains of constipation. Her only medical history is type 2 diabetes, which is controlled on diet. On examination, there is pale complexion and her skin is dry. Pulse is 50 beats per minute and regular. Rest of the examination is unremarkable. The primary care physician considers anemia and requests a full blood count, which shows anemia is confirmed. Platelet count is a little below normal and her WBC is normal. However, her MCV is raised. What is the diagnosis?
Hypothyroidism. Hypothyroidism.
Okay, anything else? Okay. So this is hypothyroidism. The important differential that they have wanted to point out is that this is not chronic fatigue syndrome, mostly because there is an absence of tender points. Okay, you can have depression as well, and depression is something which is quite underdiagnosed in the geriatric age group. However, this is a diagnosis of exclusion and should only be considered after all organic causes have been ruled out. Okay, uncontrolled diabetes can also be associated with extreme lethargy and weakness. So, this could have been an option, but the question clearly states that the diabetes is controlled on diet, so you can rule that out. Okay, a simple blood test showing you the free T4 and TSH levels and replacement with L-levothyroxine should correct this disorder. A 79-year-old veteran was seen in the emergency following a minor fall and inability to bear weight. His right leg was shortened and externally rotated. X-ray confirmed fracture neck of femur. However, the orthopedic surgeon was concerned about the X-ray appearance of the pelvis. Further inquiry revealed that he was becoming increasingly frail and prone to develop respiratory tract infections. He was also complaining of pain in the lower back, which is worse at night. Apart from cachexia and pallor, his physical exam was normal. What is the most likely diagnosis?
Multiple myeloma.
Multiple myeloma. Okay. So we have already discussed this. You can take a screenshot of this slide. What are the various presentations you can have of multiple myeloma? Next question. An 81-year-old lady with advanced Alzheimer's has inhaled her hearing aid. Her respiratory rate is 35. A bronchoscopy is proposed. Which of the following apply with regards to obtaining consent for the procedure? This is a medical legal case, a medical legal scenario. Again, not very uncommon in the MRCP. Please give your choice.
So relative should give the consent.
If mini mental score is above 20, consent can be given from patient.
Okay. Anyone else?
Doctor will be able to consent on the patient. Two doctors, if two doctors are there, they can take consent.
Okay. Any other opinion from anyone else?
It should be in the next of kin if we need a written consent.
Okay. So what you have to understand here that the question is basically asking about consent, and you have to understand the clinical scenario in which the question is framed. So here you have a lady who has inhaled her hearing aid and she has a respiratory rate of 35. This presents a medical emergency. Now for medical emergency, the procedure does not require any written consent whatsoever because it is a life-saving procedure. Okay. If it was not an emergency case or if it was not a life-saving procedure, you would have taken the consent from the patient, provided the patient is able to give you a written and an informed consent. Okay. Now, what do you mean by a written and informed? That means you have to assess whether the patient is able to have capacity. Now, capacity means whether the patient is able to understand the procedure, the need for the procedure, and under no pressure is the patient able to give you his or her consent. Now, if in this patient you have a patient who has Alzheimer's and this was a non-emergency scenario, okay, she has inhaled a small object, she is vitally stable, her respiratory rate is around 20, then you would have had to take the consent from the next of kin to perform the procedure. Okay. And please remember that doctors do not give any consent for any procedure for any patient. Okay. There is another uh, mechanism which is not prevalent in our part of the country, in our part of the world, but it is quite prevalent in UK, and which I'm sure you will read more about it as you go ahead in your MRCP journey, which is called as the power of attorney. Now, what you do is basically you appoint certain people when you have the adequate mental capacity to take decisions on your behalf in case you are incapacitated. Okay, so that is something which comes into effect if this patient would have had a power of attorney, and it would have been mentioned in the question itself that the patient has a power of attorney or she has nominated somebody to take decisions on her behalf if she is incapacitated. In that scenario, you will have to take consent from that patient before carrying out any procedure. Okay, there will be many more medical legal scenarios that you will come across uh, in while preparing for MRCP. This is just one of them, that is consent. An 81-year-old gentleman presents with deteriorating lumbar and bilateral hip pains. He has recently been seen by his GP and symptoms of prostatism. Full blood count is normal. Other investigations reveal the following. He has a corrected serum calcium level of 2.5, which is just normal. ESR is 25. Alkaline phosphatase is 990. Gamma GT is 35 and a serum PSA level of 6.7. What is the most likely cause of this man's pain?
Prostatic CA with
Alkaline
metastasis.
phosphate is high and
Sorry?
Paget's disease of pelvis.
Okay. Anything else?
Sir, prostatic carcinoma with metastasis.
Anything else? So this is in fact the Paget's disease. The reason this is not prostatic carcinoma with metastasis is two. You would expect a PSA level to be slightly higher. Here the cutoff is 6 and the level in this patient is about 6.7, which you can expect in an 81-year-old patient who is suffering from prostatism. So it is not markedly elevated. And if you have got METs, then your calcium level would have been far higher. In this scenario, the calcium level is within the normal range. The normal range calcium with a very high alkaline phosphatase
High alkaline phosphate. Paget's disease.
indicates Paget's disease. This is not polymyalgia rheumatica because his ESR is only 25. In polymyalgia, you would expect it to be 80s or 90s or 100s. This is not osteomalacia because again, calcium is more or less okay. Which of the following is associated with Parkinsonian features?
Wilson's disease.
Anything else? Okay, doctor, can you tell me the difference between Parkinsonian features and Parkinson's disease?
In Parkinson's disease, that is hypokinesia, rigidity, and tremor should be there. Sorry,
Okay,
bradykinesia, rigidity, and tremor. In
okay,
Parkinson disease, but Parkinson features all the features are not seen. Some of the features are seen, and in Wilson's disease, it is this tremor is seen, and also this
okay. So, any constellation of symptoms which resemble Parkinson disease is what you would call as a Parkinsonian features. And in case you are not able to find out any secondary cause of the clinical features, that is what is called as the Parkinson's disease. So, Wilson's disease is responsible for showing Parkinsonian features. There are certain poisons which can lead to Parkinsonism. Here, the list is mentioned. Carbon monoxide is very important. There are clinical scenarios in MRCP where they ask about carbon monoxide poisoning, and the illicit drug methyl phenyl tetrahydropyridine is again very important and is known to cause Parkinsonian features. So other conditions of the brain which can lead to Parkinsonism, again the list is given. You, as the doctor rightly said, you won't get all the features, but you may get some of them, and the diagnosis will depend on the other clinical examination and the history from the patient. A 78-year-old lady was admitted 26 hours ago following a fall. The orthopedic senior house officer asks for the registrar's help because the patient is shouting out on the ward, keeping all the other patients in the bay awake. He tells the registrar that he is not able to reason with her and that she is distracted and incoherent. On arrival, the registrar notes that her left leg is shortened and externally rotated. Which additional finding would suggest a diagnosis of delirium rather than dementia?
The patient was
Yes,
coherent in
coherent and
complaint.
compliant on admission.
That is the correct answer. So, the diagnosis of delirium is made by something called as the confusion assessment method. And there are four criterias for it. You have to have an acute onset and a fluctuating course. So that has to happen within the last 24 hours. If you read the question again, the scenario clearly mentions that the patient was admitted around 26 hours ago. So that fits. The patient will have inattention, disorganized thinking, and there will be altered level of consciousness which can manifest both as hypoactivity or hyperactivity. Okay. As per this criteria, the patient must have 1 and 2, that is acute onset and inattention, along with either of disorganized thinking and altered level of consciousness to make a diagnosis of delirium. All right. 76-year-old lady has had increasingly severe throbbing headache for several months, centered on the right. There is a palpable tender cord-like area over his right temple. His heart rate is regular with no murmurs, gallops, or rubs. Pulses are equal and full in all extremities. Blood pressure is 110/80. A biopsy of this lesion is obtained and histological examination reveals a muscular artery with luminal narrowing and medial inflammation with lymphocytes, macrophages, and occasional giant cells. She improves with a course of high dose of corticosteroids. What laboratory test finding is most likely to be present with this disease? What are we dealing with?
Giant cell arteritis.
Okay. So, what do you expect to find in giant cell arteritis?
ESR more than 50.
Anybody else?
Maybe ESR is high.
That is correct. So, we are we are dealing with giant cell arteritis, and this patient has got temporal arteritis because of the clinical features, biopsy findings, and remission with corticosteroids. So this patient will have very high ESR, and that is almost diagnostic along with the other features that have been mentioned over here. 79-year-old resident of an old age home was seen at the emergency for restlessness and aggressive behavior. He has reported history of incontinence of urine and also has had few falls. He was placed in the old age home after the death of his wife due to severe arthritis in his hands and knees. His only past medical history includes hypothyroidism, for which he takes thyroxine of 50 micrograms per day. He is disoriented in time, place, and person and smells strongly of urine. There are no focal neurological signs. What is the most likely diagnosis?
Dementia,
Why do you say so, doctor?
restlessness, aggressive behavior and history of incontinence also may be present in dementia.
It could be delirium as well. Strong smells of urine could be UTI.
And also disoriented in time, place, and person.
Okay. Anyone else wants to offer anything?
Delirium secondary to UTI.
Okay. That is in fact the correct answer. So this is delirium and it has been precipitated by UTI. We have already gone through the CAM criteria, which again, the most important two of the criteria are acute onset and a fluctuating course, and there will be inattention. These two have to be present to make a diagnosis of delirium. You may or may not have disorganized thinking and altered level of consciousness. Had this been a has had this been dementia, you would have had previous history where the patient was not being able to take care of himself, or he has had recurrent falls, or some such history would indicate something. Here, you are not being given any such information. Okay. However, there may also be a condition where the patient may have delirium and uh, superadded on dementia. That is also possible. And once you see that the delirium is getting treated, the dementia tends to come forward and become more prominent. However, acute deterioration in any condition in an elderly patient with inattention is delirium. A 72-year-old alcoholic male presented to the pain management clinic with pain in the left hip joint. He has been in good health and his only past medical history being of sudden blindness in the right eye, which was treated with high doses of steroids. X-ray of the left hip shows severe degeneration of femoral head with loss of joint space. What is the most appropriate cause of this joint deformity?
Avascular necrosis of femoral head due to excessive steroid intake.
Anyone else have any different opinion or any different answer to give? So that is actually the correct answer. And as the doctor correctly explained, because of his history of receiving high dose of steroid, he has developed avascular necrosis of the femoral head.